Morning, everyone. Good afternoon, I should say. It's almost noon.
Very close.
Yes, we will get started in just about a minute or two. Thank you all for joining. All right, it is noon, so we will go ahead and get started. Good afternoon, everyone, and welcome to the Illinois Public Health Association's Public Health Education Talk Series. For November, our talk this month is the role of public health in carceral settings, and Linda Vail is our speaker. So I'll tell you a little bit about our presentation today, and then I'll introduce Linda to you all. So during today's session, we'll discuss the current landscape of public health in jails, the impact of the jail population on public health. We'll talk about the framework for integrating jail and corrections into public health, and we'll talk about collaboration opportunities for public health and corrections, particularly as it relates to opioid use disorder and also medication-assisted recovery. And telling you a little bit about Linda Vail, our speaker, she is a principal with Health Management Associates, and she served as a public health officer in the state of Michigan for 16 years, first in Kalamazoo County, then in Ingham County. And during that time, she forged collaborations between her health departments and various segments of the criminal justice system. Most recently in Ingham County, she was responsible for corrections health, and she worked on systems integration to bring medication-assisted recovery into the county jail, as well as co-locating public health services such as peer support for case management on reentry. She also worked on Medicaid enrollment support in the jail. And just before she retired in February of this year, she successfully worked with the county sheriff to install a naloxone vending machine at the county jail, which also stocks other harm reduction supplies. That's a really great innovative program. So thanks for that, Linda. So without further ado, I will turn the talk over to Linda, and thank you all.
Well, you did such a wonderful job introducing me. I don't need to introduce myself any further, but I do want to say that Dr. Margaret Kierkegaard is here with us, and will be taking a couple of talking points here as well. She is a physician principal with Health Management Associates and is working on the Illinois Medication-Assisted Recovery Project, as is Margot, who's here with us to help with slides. So thank you. Oh, there you go. I always talk a slide ahead of myself. So this is just a basic disclosure about our project, our program, and that, these are funded through the state opioid response grant, et cetera, et cetera. So just a basic disclosure for you and acknowledgements of the state funding. This is our team currently in Illinois. Margaret, why don't you go ahead and talk to this one?
Great, thanks for that, Linda. And I apologize to our attendees that there's some yard work going on here, unfortunately, right outside my window, right at this exact moment. So I apologize that there's some background noise. Health Management Associates is a national research and consulting firm focusing in publicly funded healthcare. And for the last 35 years, we've worked intensively with correctional health because a lot of people don't recognize it as a publicly funded healthcare program, but in fact, all correctional health is derived from public funds. And particularly in the last 5 or 10 years, our work in correctional health has intersected with our opioid epidemic. And we have worked across the country with jails and carceral environments to help them develop better systems of care for SUD, and in particular, focusing on opioid use disorder and the availability of evidence-based treatments such as medication-assisted treatment, or in Illinois, as we call it, medication-assisted recovery. Next slide. We have been hired by the state of Illinois through the SOAR dollars to conduct a learning collaborative model which we have done successfully in other states to help the county jails develop systems for prescribing and making medication-assisted recovery available, in addition to prescribing Narcan and doing other harm reduction efforts and developing recovery pods and other systems of care. So we do focus on medication-assisted recovery as the tip of the spear for saving lives and reducing overdose deaths, but we really focus on that holistic care within the jails for individuals with substance use disorder. We currently have 25 jails participating in our program, 25 counties, I should say, because in many of the counties, we have a county collaborative team that includes public health. So we're grateful that many of our counties have that public health engagement. However, we also know several counties that participate where the relationship with public health is less than optimal. And so our comments today are informed not only by Linda's vast experience and her deep expertise in public health and working with Carceral Health, but our experience in Illinois. And at the end of our slide deck, we have our general contact information if you'd like more information specifically about this program that's happening in Illinois. And with that, I'm going to turn it back over to Linda. Thank you.
Thanks, Margaret. So basically, and these kind of go 1, 2, 3 in a row, Margot. We start with current landscape of jails in public health, really a conversation about where we are, because as Margaret just explained, some health departments are already very involved with carceral health. We were because we were responsible for it, others are not. Then we want to talk about the impact of the jail population on public health and how that has implications for our population health and safety, because they don't always stay in jails. They're part of our community, both in and out, and they have an impact on our communities coming out of jail if we haven't addressed issues within the jail or carceral setting. And then finally, a framework for integrating jails and corrections into public health. So how do we move from that conversation, if that's where we are, or maybe we're pre-contemplative, to that full collaboration between public health and jails, which can be so very critical and very helpful within our criminal justice system. So as you all know, as public health people, public health is everything, right? Everything is public health. And we're proud of that. So when we think about that, jails, prisons, corrections are part of the community. So again, people don't leave community just because they're inside those walls. They're still part of the community. And then what is the role of public health as the champion and sometimes the critic? Critic might be a little bit of a harsh word, but you know, critiquing and being able to help and support within those systems. So where are we right now? Currently, and I know this is really tiny, but it really is about explaining to you kind of where we are right now. This is the CDC's page for correctional health is community health. And if we blow that up a little bit and look at what's down there, it's community support, intake and entry, during incarceration, reentry surveillance. Surveillance, that we speak about HIV, viral hepatitis, STDs, STIs, excuse me, TB, but what's missing? So when you click on, Margo, this next slide, when you click on those health education materials on the CDC's website, you will find materials about HIV, materials about viral hepatitis, materials about sexually transmitted infections, lice and scabies, but no mention whatsoever about what's going on with SUDs and opioid use disorder and a lot of behavioral health issues that are very much at the intersection of public health and corrections. So what has been the role of public health in your experiences? Possibly that might be immunizations, communicable diseases. Corrections staff might be familiar with conditions reportable to local public health authorities or their health staff such as tuberculosis and other required reportable diseases. And sometimes we are looking at immunizations within that carceral setting as well. And also, we might have some education and testing for sexually transmitted infections, as well as, do I have a third point here? Some conversations around naloxone. So, you know, there are a lot of jails that basically it's like we have people come in, they're already on, you know, opioids. We might need to have some naloxone available because we don't know immediately that they're going to go in withdrawal. Then they could be coming in at a point where naloxone is going to be important in their recovery, as well as we have conversations a lot around naloxone as part of release. People who come into the jail with an opioid use disorder, do we work on making sure we release them with naloxone? So we are often considered to be the conveners, the neutral conveners around so many of our different partners and collaborators. So the science, this is a Winslow quote, the science of and art of preventing disease, prolonging life, and promoting health through the organized efforts and informed choices of society, organizations, public and private communities, and individuals. So that's from the CDC in 2014. So the current landscape. So for traditional public health, corrections is pretty much a standalone system in most places. I think it was fairly rare in my circumstance that as a public health department, we were actually running corrections health in our jail. And it wasn't always a lot of fun either. So I'll just say that. So really the current landscape oftentimes is this is a black hole, the jail, the prisons, the correction system, in which people from our communities enter, and they really aren't considered again until they now re-enter the community. Now we could argue that they never left the community, so they don't really need to re-enter. But we do kind of, you know, this population now is in there kind of being taken care of, and we don't necessarily always engage with that in our conversations about public health. So in our scope, we've really traditionally kind of ignored a lot of the incarcerated population. And that's not exclusively across the board. We were just doing a project in Maryland, and the health departments are very involved because they are responsible for a lot of behavioral health in the state of Maryland. They're very involved with a lot of their detention centers around you know, corrections health and things like that. So it's not an exclusive thing. So we recognize educational systems, hospitals, a number of other organizations as part of our broader community health, because we have social determinants of health, you know, rent, housing, transportation, education, all of those things are those social determinants of health that we talk about when we're trying to deal with inequities in our system. And so we do really broadly work with a lot of those community partners, but not necessarily our corrections. So have we really, we probably have in most cases, really siloed this critical partner and contributed in a sense to then stigmatizing that group within the larger community, because as soon as they're not in our larger community, they're not part of us anymore. And that is a population which really has huge implications for population health outside of that correctional setting. We are, especially in jails, you know, those people are coming back into your communities. And if we're not addressing concerns and issues in education and public health education around any number of things, then we do have those individuals back in our community, and then we're dealing with the issues that present to us at that point in time. So we continually see and hear and have conversations as if populations in our jails and prisons only have impacts in those four walls rather than outside of the four walls. And we really need to start looking to that as a more kind of integrated way of looking things in a more of a kind of a timeline of where they are rather than they're here and they're not here. So let's go ahead. The next. So drug and alcohol intoxication is the third leading cause of death in US jails, and overdoses continue to impact our communities. Many leaders in public health and federal public health leaders continue to provide guidance and recommendations for correctional health and detention centers for things like vaccinations. But as you saw when I brought up the CDC information, we're not really talking a lot about overdose or implications of those diseases and conditions beyond the carceral setting, the jail or the prison. So public health and the role of overdose education and naloxone distribution in jails and settings prior to reentry is one of the things that we do kind of tend to connect with our jails about, talking about, you know, naloxone. Sometimes we're kind of their gateway to getting access to naloxone. At least I know we were in our community. We had community partners that had given us grants to pay for it, and then we worked with our jail. Go ahead. So we also are appreciating and recognizing language in this multiple disciplinary environment. You know, we have language and acronyms and things that we use. They do the same thing in corrections, in jails, as you know, just across every sector. So we have an appreciation and recognition of that language in multidisciplinary environments. And we really want to challenge our public health and community leaders to also consider, like I just mentioned, the term reentry and the implication of that, that an individual stopped being part of the community and then re-entered the community. And I'm going to use reentry throughout this presentation because that's the word we use. But when we really think about that, you know, is that one of those kind of stigmatizing words where it's like, re-entry, okay, you weren't part of the community, now you are again. So what are the impacts of the jail population on public health and safety? So about 2.3 million people are incarcerated in the United States, and about 7 million people get released from jail every year. People who are incarcerated are much more likely than the general population to experience chronic conditions and acquire infectious diseases. So, you know, not even talking about SUDs, OUDs, and that sort of stuff. That is huge with this jail population and carceral setting population. In the past year, people who were incarcerated were about 5 times more likely than the general population to test positive for COVID-19. So with 7 million individuals released from jails, that's a large number of people. And chronic diseases are now not confined to the walls of the jail. We really have also seen that COVID knew no boundaries as well. Yeah, you know, probably all of you, as I did, dealt with multiple outbreaks in your jails during the COVID times. We call them the COVID times. Yet we really still talk about these issues in public health more within the 4 walls of detention and aren't necessarily connecting it to basically the outer, you know, when people, again, re-entry, tricky word, and really making that kind of a seamless, more integrated process. So we should talk about public health over the continuum of all of that. So incarceration, in fact, is one of our structural determinants of health that worsens population health, as well as education and poverty, income, housing, all of the things that we talk about a lot when we talk about structural determinants of health. Black Americans are incarcerated in state prisons at a rate that is more than 5 times higher than that of white Americans. Communities with high rates of incarceration are also more likely to experience poor mental health. We see in, you know, jails oftentimes 80% or more of individuals that are incarcerated who have behavioral health issues, behavioral health and substance use disorder issues. So that is very much a huge part of what's going on in our community during that period of incarceration. Families of people who are incarcerated experience community fragmentation, disruption of social ties that then negatively affect their mental and family health as well. So the health risks of incarcerations are then heightened after release. So a lot of the things that were kind of simmering or boiling or stabilized within that jail setting, oftentimes at a time of release, there is not, that warm handoff, or again, that continuum. And so then we have health risks that are, sorry about that beeping, I don't know how to get that sound to turn off, that are heightened after release. People recently released from incarceration are more likely to die in the first 2 weeks following release. And the risk of deaths among formerly incarcerated individuals was 12.7 times higher than that of the general population. Now that's across the board. That is also a statistic that's very true, and I might be talking ahead of my slides again, on opioid use disorder. The risk of overdose is significantly higher in the first 2 weeks after release, and then continues to be high for a while. But we still talk about these issues in public health and corrections, again, so why do we talk about these, within the four walls, outside of the four walls, instead of looking at that continuum, and also looking at the individuals that are housed in our jails are no different than individuals from our community that are housed anywhere else. A little bit more of a controlled environment, but so we've gone on record declaring violence, racism, the opioid epidemic as public health crises. So if we do that, we need to take that to action and say that we need to integrate jail and corrections into the larger public health conversation and start reframing it to be included as part of the larger population, the larger community. Not just when they're back in community, but the entire time. They're always part of our community. So how do we have a framework for integrating jails and corrections into public health? How do we move from this conversation to collaboration and then action? So you all are probably very familiar with the public health triangle. So at first in this presentation, it first explained the public health triangle, and I realized I didn't need to explain the public health triangle to all of you. So, at the bottom, we've got that primary prevention, middle, secondary prevention, top, tertiary prevention. And we know that at the primary prevention level, that foundation is where we have the greatest impact on basically health outcomes. When you look at how the spectrum of substance use disorder, opioid use disorder, kind of spread out across our triangle, we see that things don't, there's a continuum, but it kind of bounces around within where we look at things. So we've got some things down in primary prevention that are more coded as tertiary prevention, et cetera. This will make more sense when I show the next slide, or the next two slides. So when we look at the public health spectrum, and these are now color coded according to the green, red, blue, this is not a linear thing. So we're not looking at the different ways that we can interact with, engage with, have impact on reducing disparities, improving health outcomes in any kind of a more linear fashion. This kind of bounces all over the place from our primary, secondary, and tertiary prevention perspective. And that means that you can be really looking at three things at the same time that are in three different areas of the triangle. So we've got early on in the continuum having an SUD. Recidivism is a prevention thing. Overdose is obviously way at the other end of the triangle. So it's really, we've got lots of opportunities to intersect at the primary prevention level. We've got lots of opportunities to intersect at the secondary prevention level and the tertiary level, but it's not necessarily going to be linear. And quite honestly, it's probably never very linear when you're dealing with diabetes or high blood pressure or any of that either. We have relapses and all kinds of things that go with that. So next. So we can start with having conversations like we're having today and start some cross-education, cross-understanding with public health partners needing to help. We need public health partners need help understanding jails and corrections and vice versa. We don't necessarily always understand what's going on in our correction systems because we don't have that integrated continuum at this point in time in most places. And we don't know the challenges, a lot of the challenges that they face within their normal environment in a day. And likewise, they need help understanding where it is that public health can be a part of everything from, quite honestly, specialty treatment courts. We've been involved with our specialty and treatment courts, drug court, mental health court, things like that, as well as with probation, as well as in our jails. And so really, when we look at that integration, it requires understanding. We want to understand what you as a partner do and how your activities and strategies impact the work that I do, and vice versa. This understanding of how work in corrections, et cetera, how that all works, what are your goals, your barriers, your challenges, and how does that work affect our work? So I like this quote, except I always want to correct what feels like a bad wording in it. So, but it's 1958, so that's the way it goes. The landmark of political, economic, and social history are the moments when some condition passed from the category of the given, and this is where I like to say, it should say into, but it's not, in the category of the intolerable. So Sir Geoffrey Vickers then said, I believe that the history of public health might well be written as a record of successful redefinings of the unacceptable. And I think when we start to look at many things that have become in the public health world considered at one point in time the given, and then basically become intolerable. Do we successfully get everybody to agree with us that it's intolerable all the time? No. But we stand on a lot of things as being intolerable. Racism is intolerable. Gun violence is intolerable. And so we dig in and we work on those issues with our community partners across the board to make those changes. So really, public health is, we're redefining unacceptable really at a remarkable pace as we've kind of evolved in the last, I don't know, I've been in public health for over 20 years now. So I've seen a lot of changes. And it was really interesting to find this quote and really realize that, yeah, public health is going to be, a successful redefining of unacceptables. And I think that the history books are going to show a very favorable outlook on public health during the COVID pandemic as well, even though we got peed up pretty bad in the last 3 years. So actually it's going on 4 now. Go ahead. So when we integrate jails and corrections into public health, we sometimes start with the corrections staff saying, well, I house offenders to keep my community safe. And then we go to our correctional health system that says, I'm treating the same inmates over and over again. Probably some frustration there. The behavioral health system, ready and waiting to treat patients. But since the correction staff is like, I'm just housing to keep my community safe, they're not necessarily saying, here's where you need to get some help from our behavioral health system. They're waiting to treat patients. And then our public health system is, again, we have all these programs. Why isn't our community getting healthier? Now, not that the jail is the only place, but that is a missed opportunity. We lose lots of people in our systems, but we do have incredible programs and diverse programs, and really strategizing at our most vulnerable community partners, community members. Vulnerable is kind of a challenging word to use as well, because I work with Dr. Richard Hofrichter at NACHO on their Health Equity and Social Justice Committee, and he was very instrumental at reframing a lot of the definitions and discussions around health equity. And it's like, they aren't vulnerable, they were made vulnerable. So even that is language that we oftentimes struggle with and have started shifting away from, which goes back to, we deal with the intolerable, the given, and start to turn it into intolerable. So what are words we can better use than vulnerable, because these community members were made vulnerable. So they experience barriers in access and all of those sorts of things as well. So we have a lot of programs that address those issues. So we can move to the correction staff saying, I understand that care inside my facility should be the community standard of care. which ultimately leads to reduced recidivism. The community standard of care is in the American Society of Addiction Medicine, at the level of, you know, the Drug Enforcement Agency, of, you know, of many players around this game, or this situation. We are basically looking at standards of care. There are standards of care for mental health. There's standards of care for opioid use disorder. There are standards of care. That standard of care should not change within the correctional system. And unfortunately, it oftentimes does. So when we get our correction staff kind of with us and all of us working together, then they understand that we should be using a community standard of care inside the corrections facility. And ultimately, there is a goal in that is worthy of their consideration, which is ultimately that does lead to reduced recidivism, because you're dealing with mental health, behavioral health, substance use, chronic health conditions, all during that period of time of incarceration. So in the correctional health system, or yes, corrections health. So it's corrections health within corrections. So corrections health system, work with partners, you know, their mental health partners, their community treatment partners, their public health partners, and more, to treat addiction for community members inside of the jails instead of treating the symptoms of addiction. So I know you've all seen it, because I have, you know, people who end up in jail and then just end up in a cell, kind of just cold turkey withdrawing from their opioids over a period of time, as opposed to there are standards of care that basically say that is not the way people should be detoxed or should withdraw. They should be provided treatment. They should provide medical treatment, these medication-assisted recovery, different drugs that we have. That is a community standard of care, and that is the type of care that should be expected within the corrections health system. The behavioral health system is working with partners to support community members with addiction, regardless of where they are in the community. Again, we're all in the community. We're in a nursing home, we're in an apartment complex, we have our own homes, we're in an orphanage still. Every now and then we deal with that. We have lots of, you know, congregate settings like that, and we also have our jails and prisons. So then as public health people, we go, well, I understand that community members transition in and out of incarceration, and that transitioning in and out of incarceration impacts population health. And so then it becomes important for us to prioritize, again, that continuum of paying attention to what's going on with these community members in the community, in the carceral setting, in the, you know, sometimes there's a pre-release, you know, program where they're in, you know, parole, probation, those sorts of things, and then, you know, out into the community completely. So if we're only considering and discussing within the four walls, we're missing opportunities, as we know that these community members transition in and out. So here they are going into jail. We're not going to be here forever. And then on the other side, really with, you know, kind of the same look they had going in, although, you know, a little bit different. So just some, you know, Illinois math here. So Illinois has 92 jails in 102 counties. As of December 31st, 2020, you know how stats are, they're always a few years behind. The estimated average daily population in Illinois jails was 19,120. About 8% will go to jail 3 or more times over the course of the year. We call them frequent flyers. I know you've called them that before too. Frequent flyers in emergency rooms and jails, which is also a frequent user service enhancement. I don't know if you've heard of that, FUSE programs and things like that. Huge focus in public health to deal with these issues of emergency rooms and jails and the repeated cycle of going into emergency rooms and jails, which aren't the best places for people to end up if we're taking care of their health. Oftentimes it isn't where they're going to end up. So estimated that 9% of the population is detoxing from opioids when they're in those jails. We need protocols in place that include comfort medications for experiencing withdrawal, and also medical detox that typically includes a variety of medications over a period of time that also requires that ongoing medical supervision, which in corrections health is quickly going to be about, well, that's time and money. And they're always watching that contract with their medical provider if they have one, or however they're managing their corrections health. That is a pretty tight contract, and they're always watching for what's going on with time and money. But at the same time, they're also trying to make sure that they are reducing their liabilities, because it's a highly, I mean, jails get sued frequently. And rest assured, there's going to come a time when they aren't providing community standards of care inside of a jail, and that is going to be part of a lawsuit for that jail. So just some proxy math on that. On a given day, an estimated 9.6 or 1,836 people with an OUD are in jail in Illinois. Adding in the prison population from Illinois, we get up to about 2,854. So not accounting for opioid use disorder impacts on recidivism, of those 4,690 individuals with opioid use disorders, 375, back to that 8%, are frequent flyers. So that is meaning you're going to treat them at least 3 times in the next year, which is about 1,125 encounters. So when you start to talk about time and money, then are not addressing these issues and allowing this frequent flyer situation to continue without figuring out ways to better intervene with that and work together to prevent that is costing a lot of time and money, as well as, importantly, lives. So integrating jails and corrections into public health is going to benefit, and there are benefits for our community members. It improves population health overall. It reduces compassion fatigue. It inspires the workforce. And in the end, it really does save time and money, as opposed to, you will hear, it's like, well, if we have to do that and have this supervised medication and introduce these medications, they're expensive medications. You start talking about some of the injectables that are, you know, $1,400 or so a shot, right, Margaret? Or an injection, something like that. Yes, she nodded.
Yeah, actually closer to 2,000. So
right. So that's naltrexone, and is it Sublocade?
Correct. And Brixadi is a new injectable that's buprenorphine that was released in the last month or so in the United States.
So I think we might be getting close to the end. Oh, not yet. So I think I'll let Margaret also talk to this learning collaborative a little bit more, because I'm just going to read to you. I've been a subject matter expert. I'm, you know, just geeked as can be to always talk public health to public health people and non-public health people, and have really, really had a passion for a long time. I started speaking around the state and even sometimes nationally about opioids, the opioid epidemic and opioid use disorder back in 2015. So leading up to getting all of that work going on in my community with my jail, which actually turned out to be a project that HMA was involved in. I was coached by an HMA person before I even knew I was going to be part of HMA with our jails. And so I just think that this is such critical and important work. And, you know, as many of us do, you know, I have a personal story that goes with this too. And many of us HMA have personal stories that go with this as well. My partner had a son who was a professional musician out in California, very, very successful, toured with Bette Midler, played with Stevie Wonder, Alicia Keys, John Legend, Chaka Khan. He was soaring. But then he decided that he needed to soar a little bit more with some drugs. And so he got hooked on heroin and fentanyl. He was able to supply his habit very well financially, you know, afford it for a while until, as is common, just not able to keep the things in life together until he was on the verge of bankruptcy, on the verge of repossession for his house, and then got in trouble with the criminal justice system and was incarcerated in late December of 2017. His parents were wise enough not to bail him out, but some of his friends bailed him out after about a month, when he was really finally getting to that point where, when you're dealing with somebody with an opioid use disorder, you can have conversations with them that they can kind of, get involved with and start to work on that treatment path. And that's one of the reasons that medication-assisted treatment at the point of withdrawal management is so important, because that gets us to a point where people can work with us on the other issues. So he's at that 1 month point. He gets bailed out. He overdoses and dies 2.5 weeks later. And that is, unfortunately, a very common story within our criminal justice settings when somebody gets released who hasn't had appropriate behavioral health therapy, substance use disorder treatment, opioid disorder treatment in the jails. We can prevent these deaths. And I'm going to let you talk about the collaborative, Margaret.
Sure, thanks for that, Linda. So as a family doc myself, I'm relatively new to correctional health care. But prior to becoming engaged in it, I really had no recognition that it is just another place where primary care happens for individuals, and important primary care, and important to create that continuity of care in and outside the jail. And on top of that, as a public health practitioner, the importance of public health taking care of everybody in the community and not regarding those people who are in jail or prison as somehow being segregated or outside of the community is so important. So this issue of correctional health care and SUD is at a crisis point because of the opioid crisis and the accelerating overdose deaths in Illinois and the rest of the United States. But we strongly support that engagement of public health for all conditions within the jail: smoking cessation, chronic disease management, STIs, management of COVID. And some of you may have emerged from COVID being best friends with your jail, and others of you may have said, okay, we're no longer on speaking terms because that was just so hard. We get that. This learning collaborative is available to all the jails in Illinois, except Cook County. I apologize to Cook County. Cook County has worked in a tremendous way to develop systems for medication-assisted recovery. And so they're not technically allowed to join the learning collaborative, but we have had some interaction with our Cook County partners. I'm from DuPage County, and of course the HSA in Cook County came from DuPage County. So we have some collaboration with Cook County, but the official learning collaborative is available for the rest of the counties, regardless of whether or not you have a jail in your county. And it really does create a framework to tackle that issue of overdose deaths and substance use disorder in a collaborative way. And we've had some counties where their participation has been led by their public health department. So it's really an example of that a collaborative spirit that Linda was talking about. I encourage everybody to look at our 15-minute video. It's making the case, and in this video we do have correctional health individuals. We have Sheriff Hain from Kane County. We have a couple of public health practitioners from DuPage and Lake County talking about their interactions with the jails and the necessity of that. And if you have the opportunity to share it in your county, then we encourage you to do that. And Margot, I don't know if you're able to cut and paste and put that link directly into chat, so that I think maybe it's a little easier for people to then click on it and bookmark it so you have it available. And we're happy to talk about the components of the learning collaborative in greater depth. If you have any questions, you can reach out to our general mailbox, which will be on the last slide, I think, that will show here. And with that, I'll turn it back over to Linda, and maybe we can open it up to some questions.
I think that is where we are, Margo. I think the next slide is just my contact information and the Illinois MAR Learning Collaborative contact information. And you know, it was nice to quote take the podium again and do a public health talk. I was just talking to Jeffrey before we started. It's like this is so hard for me because I'm used to walking around and pacing the stage. I've gotten to where I was using less PowerPoint and just more talking. And it's like, you do it over Zoom. I can't pace. I've got to use PowerPoint because you're just going to stare at my face the whole time. I'm not even giving you any dynamics by walking around the room. So here we are. I'm sitting in front of a camera. You're sitting in front of cameras. We have PowerPoint. Hopefully we didn't, give you death by PowerPoint and provided a lot of useful information for you. And we are happy to answer any questions that you might have, as well as letting you know that you can send questions into those things. So
absolutely. Linda, thank you for an amazing and very enlightening presentation. So if folks do have questions, you should feel free to unmute yourself and ask the questions or raise your hand like Mike did, or put it in the chat. Mike McGinn, it looks like you have a question. Go ahead, sir.
I do, and I apologize because I have a cold. But thanks, Linda and Margaret. That was a great informational presentation. My name's Mike McGinn, and I work for Illinois Public Health Association as their HIV prevention team. And couple questions. Are you working internally with IDOC with like their peer navigation program? I know they kind of started that with HIV and STIs, and I think kind of fell wayside, but it's still, I think, a valid attempt to be able to work internally with inmates. So I throw that out there. And then how are you coordinating with the statewide reentry initiative project, which I participate on, and then also the local, like we just had a Central Illinois reentry task force meeting yesterday. And are you collaborating with them at all?
Thanks, Mike. I think those are specific questions about our work in Illinois, so I'll tackle them. In regards to IDOC, that's a bugaboo for a lot of our counties because, in fact, they'll get somebody started on medication-assisted recovery, and they'll go to IDOC, and IDOC will withdraw them from medication-assisted recovery. A fact that Linda did not have in her slide deck, which should really speak to all of us here, is that less than 1/4 of the individuals who are on a recovery program, they're on community prescribed medication-assisted recovery in terms of methadone or buprenorphine, will arbitrarily be removed from those medications when they come into jail, not because it's clinically appropriate to remove them, but because the jails don't do that here. And that to me is a true tragedy where you've interrupted somebody's treatment program. I mean, it's tragic all the way around if they don't get medication for withdrawal management, et cetera. But in my mind, to arbitrarily interrupt a treatment program is like taking somebody off of their seizure meds or their diabetes medications. So particularly egregious and a violation of the Americans with Disabilities Act. However, HMA has just recently started to work with IDOC, so I give them high marks, even though they are not adhering to the standard of care, to working towards getting there. I'm not familiar with their peer navigation, HIV and STI reentry or peer navigation program, but they are beginning to develop a pilot program in Logan and Decatur for women, and so they're beginning to offer medication-assisted recovery. And Margot, you have more information to add to that.
I was just going to add that in those conversations, there has been a lot of talk about preparing for reentry and making sure that they have the capacity to support people. The HIV and other reentry program has been mentioned as a possibility for sort of folding STD OUD services into the work of that group, but I don't think it's been finalized or confirmed yet.
Thank you. And then Mike, you were referring to the statewide reentry program. Are you referring to the program where people can come back to their county jails for 6 months when they are leaving IDOC? That's the optional program. Is that your you're on mute.
I'm sorry. It's actually funded through the Illinois Department of Public Health. And it's again, a statewide initiative to bring correction systems and community-based organizations together to make sure when individuals are being released from the correctional setting that they have the appropriate connections and documents and support so they don't fall back into this reoccurring recidivism, and provides them some kind of real outside support. And a lot of times, not being released back to where they were arrested from, because it just put them back in the same environment that, created the whole problem.
Right.
Great. I don't think we are specifically working with that program. We are definitely working in many counties on re-entry. And as much as we all don't like that term, it is the term, but that's a particular plank of our program. I'm going to put my contact information into the chat here. And Mike, if you'd be so kind as to contact me, and maybe we can have an offline conversation about that specific reentry program.
And I would just add that we had a Michigan prisoner reentry program that I was part of that task force way back since the mid 2000s. And it really is a great model for, we're preparing for reentry. And do you have a driver's license? Can you get a birth certificate? Where are we with diabetes, hypertension, HIV, any number of things. So it really is a nice, many community partners at the table talking about those things. It's more related to the prison, not the jails, correct? But still a great model to bring to jails. I also love peers in jails as part of the model.
It's a great resource. Dwayne, it looks like you have a question.
I have many questions, but I'm not sure what they are. So I think I'm the only local health department administrator on here today. I kind of just found out about it last evening from Connie, and I wish I could have had time to get some more of my colleagues, on this call. So I represent Henry and Stark County, kind of in the center of the state. Obviously, both of my counties are very different. Stark County, we provide the jail nursing for Stark County, but Henry County has a company that I've never in my life communicated with until they had a full-blown outbreak, during COVID. But then it was still more with jail staff. So, I guess a lot of my questions is how, and I'm sure, I guess first of all is how can we get this group to speak to our health department group? We have an association, so I'm sure many of them would be piqued by what you're talking about. They're just not present today. So I'm not sure what situation a lot of them are in as far as who's providing the care to their jails, or if health departments are doing it. I'm sure that I think health departments did a lot of that type of work early on before the correctional health systems came about. But
yeah.
And then obviously the questions that's going to come from your locals is funding. Are these billable services? Do people maintain their insurance when they're incarcerated? Who funds this? Because that's where we wind up that we're already very poorly funded and underfunded in our areas anyway, and we're probably not going to take on any additional work, because we just can't. We're so limited. So I mean, I have lots of questions like that. So
thanks for that, Dwayne. One, if you have an interest and an avenue for us to talk to more of your public health colleagues, public health administrators, maybe I'm speaking out of turn, Margaret, but we're happy to do that.
Yeah, well, we have meetings
yeah.
for the general membership like every other month, you know, so in which we typically would invite people like yourselves in to come speak about, you know, initiatives, you know, such as this, or we could work with IPHA and offer something of a different platform at a different time, maybe outside of our meetings. But I'm the outgoing president, you know, so I'll be done December 31st, but I am the president-elect for IPHA. You know, certainly still involved in my administrators association, but we do work very closely with Connie, Jeffrey.
And you'll be the past president, which at least here keeps you on that executive board.
Yeah, it does. It does.
There you go.
So,
and
yeah.
Here in Michigan, you get to be the president again if the one in front of you resigns.
That just happened to me.
As opposed to the president-elect, it becomes you again.
I just served my second term in a row because our incoming president resigned her position. So I got to do it twice, you know, so I'm very fortunate.
Yeah. So with regard to billing and other conversation about that, typically you cannot bill Medicaid when somebody's in jail. They're unenrolled from Medicaid essentially when they're in jail. Because we did operate corrections health, we would enroll people into like a Blue Cross Blue Shield plan that we had available to them if we needed to take them out for care or to the emergency room. And that's the only way we could have that stuff covered. So I also ran federally qualified health centers. So a lot of our staff that was over there were kind of connected with our federally qualified health centers. And again, for them, it's not billable. And so it was really tough. Right now there are, and I don't know where Illinois is on this, but Margaret will know, there are some Medicaid waivers. There's section 1115 waivers. And those waivers, depending on how they're written and how they're being used, will bring Medicaid covered care into the facility for about 90 days. Like I said, people write their waivers different ways, 90 days pre-release, and allow for a lot of things, as well as connecting people to, you know, social determinants of health related services on the outside as we're re-entering. So again, we're using those inside and outside and re-entry words because that's just the lingo we know, even though we know that we need to start moving away from it. Margaret, do you have anything to add to that?
Sure. So Illinois did submit an 1115 waiver that does include re-entry services. It specifies that demonstration will start in Cook County, and especially because they have county care and they have the county health system. Cook County Health and Hospital System runs the jail healthcare. It's kind of all part of one system, and then it will be expanded to the rest of the state. So that's in progress with the feds, but I don't think we'll see it in any place outside of Cook County for a couple years. In regards to who pays for the healthcare, that is a county responsibility, either through their contracted healthcare vendor, WellPath, Wexford, Advanced Correctional Health, Quality Health. There's a lot of different companies that do this, or through county paid services. However, that's part of our job in coaching to be creative. And we found that a number of community agencies have super funds that can pay for medications and provide services in the jails. And we also talk about the fact that this reduces workman's comp because it improves the working environment, reduces aggression. So Kane County has some good data on how they've reduced workman's comp claims. We have helped jails prepare statements to their county board saying this is the standard of care and we need to do this and take care of our individuals. There's a lot of good national data. Well, I shouldn't say a lot, but there's some pretty good national studies that show that it reduces recidivism and reduces costs and saves lives. So we help the jails develop their case to provide funding for these services.
But these aren't services why are the companies that already have these contracts, why are they not providing them?
Well, that's a great question.
Yeah.
I love public health and I'm happy to do that, but why isn't that the standard of care? Why the county is going to be less likely to pay me to go in because they already see it that they're paying this company to do such.
So historically, the contracts are written between the county jails and their healthcare vendor. And they typically have something in there that says, you're going to take care of chronic health conditions and you're going to take care of, mental health conditions. But somehow medication assisted recovery has always been separate from that. So there isn't a separate contract that says, well, we're going to provide seizure disorder medications. They just do it as part of they have to manage seizure disorder if somebody shows up with seizure disorder. But this has always been sort of segregated and regarded as voluntary. And so many jails have to execute a separate contract for the initiation, for the management of medication assisted recovery in their jails. And that does cost more money because the jail healthcare vendors aren't going to do it for free either. So that's where we help the jails go to their county boards and say, we have to expand our contract with WellPath or whoever it is to manage this. And use some of the available resources. Some of the jails are actually using MAR now, which is, a statewide program for medication assisted recovery, completely free. So we help the jails be creative and strategic about it.
Interesting.
And we're happy to talk to anybody at any time. You have my email there. Or we can talk to any group, whether it's Zoom or in person or.
But you're speaking right to many of the challenges. That's like, it's going to cost us too much. It's like, it's going to cost you too much not to. It's too complicated. Well, you need to figure it out. We're trying to keep drugs out of our jail. Now you're trying to bring them in. It's like there's so many just barriers to what really is a standard of care. It's taking care of our communities and our community health, and it's treating people with dignity, no matter what their chronic condition is, as opposed to stigmatizing people.
Yeah. And I look at my Henry County Jail. That's our county population, plus they have federal prisoners in there. Plus they have out-of-county prisoners that will come from the Chicago and Collier counties. It's quite the interesting makeup of our county jail here. It's just that we have space, so we rent that space out to the other agencies.
Well, I see we're out of time here, but Linda
Yep.
and I and Margot, we all, send us an email, invite us to talk. We'd love to be engaged. We are grateful for our partnership with the Illinois Public Health Association. We did talk at their annual conference. We're grateful to be invited and to continue to engage because this is a public health issue, isn't it? We need to reduce the overdose deaths. And one of the key ways of doing that is to work with individuals who are incarcerated. So thank you for that partnership.
Absolutely. Thank you to Linda. Thank you, Margaret. Thank you, Margot. They did put their contact information in the chat, so you can feel free to reach out to any of them. And this does conclude our presentation. We thank you all for being here today and hope that we can all stay engaged on this topic because it is extremely important. Thank you all.
Thank you.
Thank you.
Thank you.